Well, thank you so much, Dr. Delahose. It's very kind of you to say, and the data center is always open to people reaching out uh, for things that they're interested in trying to study. So as you noted, today we're going to talk about a recent publication that focuses on gastroesophageal reflux disease in the World Trade Center Health Program General Responder Cohort. The publication was in the American Journal of Industrial Medicine. And you can see the authors and affiliations there. The people italicized, myself, Mr. Sabra, Doctors Sachs and Kwa, Professor Todd, who's our director, Nancy Stone, who's an epidemiologist working with the data center, Professor Teitelbaum, who is a deputy director, are all from the data center, and the other authors are directors of the clinical centers of excellence, where the members are seen for monitoring and treatment. So just to let you know that that's what the source of this talk is going to be. In terms of conflict of interest, the authors and presenters declared no conflicts of interest. And we wanted to say that the contents of this presentation are the sole responsibility of the authors and do not necessarily represent the official views of, nor any endorsement by the National Institute for Occupational Safety and Health, the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services, or the U.S. government. It's been a while since I've done this, so please let me know if I'm going too fast. Background on the WTC Health Program. The cohort consists of workers and volunteers who were part of the rescue and recovery efforts that followed the attacks on September 11th, 2001. These attacks occurred at the WTC, the Pentagon, and then also there was the plane crash site in Shanksville, Pennsylvania. Members of the fire department of the city of New York are seen in a separate cohort. The GRC is a self-selected open cohort that began to form within a month of 9/11 when rescue and recovery workers began presenting with respiratory complaints. And it began to formalize in the spring of 2002 when the original World Trade Center worker and volunteer medical screening program was funded. Since 2002, the Centers for Disease Control and the National Institute for Occupational Health and Safety should be safety and health, I believe, and philanthropic sources have provided for medical evaluation, physical and mental health monitoring and treatment to those directly affected by 9/11 related rescue and recovery efforts. And on January 2nd, 2011, President Obama signed into law the James Zadroga 9/11 Health and Compensation Act of 2010, which is known as the Zadroga Act. And this amended the Public Health Service Act and established the World Trade Center Health Program. In 2015, the Zadroga Act was reauthorized and extended through 2090. Some of the eligibility criteria are that a person will have worked or volunteered on the effort for either greater than or equal to 4 hours from 9/11 to 9/14/2001, or greater than or equal to 24 hours in September of 2001, or greater than or equal to 80 hours from September 11, 2001 to 12/13/2001. That was later extended to July 2002 with the Zadroga Act. Or if they handled and processed relevant human remains as a member of the Office of the Chief Medical Examiner for New York City, or if they worked for the Port Authority Trans-Hudson Corporation, PATH, and spent greater than or equal to 24 hours between February 2002 and July 2002 cleaning path tunnels, or if they were exposed to debris from the former WTC while retrieving, driving, cleaning, repairing, and maintaining vehicles contaminated by airborne toxins. For the GERD study, a little bit of background. Gastroesophageal reflux disease is fairly common. It affects between 18 and 28% of the general U.S. population. And it is the second most common WTC-related condition. 36% of the GRC have a certification for GERD through the program. GERD is a chronic digestive condition. It is commonly identified or diagnosed by its symptoms, for example, heartburn or acid regurgitation, and also by patient response to short-term first-line medications such as PPIs, or lifestyle modifications, including weight loss, head elevation in bed, and eating earlier before sleep. The etiology of the disease and its manifestations vary, and there's no gold standard diagnostic tool. Upper endoscopy is the most frequently used diagnostic tool. Laryngoscopy or monitoring pH levels for chest pain are also used but are less common. Goals of the study were to assess the extent to which the GRC reported GERD-related diagnostic procedures and treatments, and thereby provide insight into existing WTC health program coverage and gaps in care. And we wanted to determine the characteristics of GRC members who experience GERD and assess how therapies and potential outcomes, including things like Barrett's disease and esophageal cancer, were associated with GERD resolution. Source of the data, analysis period, and inclusion criteria were as follows. The WTC Health Program initiated periodic health monitoring on July 16, 2002, and the study data are through December 31st, 2022, so more than 20 years of data were reviewed. The GRC is an open cohort, and new members continue to enroll. There are 5 clinical centers of excellence who perform physical examinations and administer questionnaires as part of the annual monitoring. The study inclusion criteria were that members needed to have provided written consent to use their data for research, and you can see about 93% of them did. And of those, 19,000 who were included had provided responses to questions about GERD, physician's diagnosis and treatment. And we also wanted to assess resolution. We needed reports of, when GERD began, post 9/11, and also what resolution dates may have been reported by members. And we needed to have longitudinal data that was greater than or equal to 1 year after the initial reports. Ethics review and approval. The WTC HP research was approved by the institutional review boards of the General Responder Data Center and clinical centers of excellence. The research was conducted in concurrence with principles of the World Medical Association Declaration of Helsinki from 1975 as revised in 2013, and National Institutional Committee's standards regarding the conduct of human studies. As noted earlier, written informed consent was obtained from all members included in the study. GERD diagnosis and treatment. So for diagnostic procedures, the initial health evaluation that the program uses, or visit 1, does not systematically assess endoscopy or laryngoscopy. So from visit 2 and afterwards, we do ask questions about endoscopy, laryngoscopy, and nighttime pH monitoring. There are also yes/no questions that ask about behavior modification and treatments, such as bedhead elevation, dietary modification, and the use of medications, proton pump inhibitors, histamine 2 receptor antagonist, and program-approved antacids. Our outcomes were as follows. We looked at the first time after 9/11 GERD resolution was reported. Most of the members had unresolved GERD, so they reported a first diagnosis date, but no reported resolution date. For those we ended up classifying as having intermittent GERD, they reported a first diagnosis date and later reported a resolution date, but then also reported a subsequent GERD date after they had reported resolution. For those who were classified as resolved, these are people without any reported relapse. They reported a first diagnosis date and later reported a resolution date, but reported no subsequent GERD or resolution. The definition of GERD duration is as followed. For the unresolved group, it's the most recent visit date minus the earliest date of reported diagnosis. For the intermittent group, it's the most recent visit date with reported GERD minus the earliest date of diagnosis. And for the group that was resolved without reported relapse, it's the date that they reported their GERD to be resolved minus the earliest date of diagnosis. We also looked at progression to Barrett's and esophageal cancer. Exposure temporality. GERD resolution status for those who reported treatment. For those who were classified as unresolved, GERD treatment procedures received for GERD were classified as exposed before and after their unresolved GERD diagnosis. For those with intermittent or resolved without relapse groups, the GERD treatments received before their earliest resolution date were classified as being exposed to those treatments before resolution, or if you will, when they were experiencing GERD. GERD treatments reported after the earliest date of resolution were classified as exposed after they were GERD was resolved. GERD resolution status for those who did not report treatment was classified as unexposed during and after GERD. Exposure temporality for those with intermittent GERD. So this is the percentage of members with intermittent GERD who reported using a GERD treatment modality. So again, the modalities are bedhead elevation, diet modification, proton pump inhibitor use, H2 receptor antagonist use, and program-approved antacids. And you can see during GERD, the green bars, the orange bars are the after resolution. Interestingly, I don't know if Dr. Stone will want to say something more about this at this time, but the only thing that kind of goes down after resolution is the use of PPIs. But that was a thing that we noted. All the other things kind of increased. So for the exposure temporality for those with resolved GERD, again, we have the same 5 things that we're looking at: bedhead elevation, dietary modifications, use of PPIs, H2 receptor antagonists, and program-approved antacids. So you can see during GERD, or what the percentage reporting what was used, and then afterwards, how many were using those same things. So our statistical analyses, we conducted 4 independent binary logistic regression analyses. The outcome variables compared those with intermittent resolution to those who had unresolved GERD, and those with resolved without relapse to those with unresolved GERD. We adjusted for the following variables: the age at diagnosis, sex, race, Hispanic ethnicity, marital status as reported at the initial health evaluation, lifetime cigarette smoking status, BMI measured at the first visit, whether they reported working on the site on 9/11/2001, the occupation that they reported having on September 10th, 2001, and we also looked at GERD follow-up in order to assess recall bias. So the 4 binary logistic regression analyses produced quite similar results. The independent variables were whether they had reported having an endoscopy or laryngoscopy at visit 2 or afterwards. And also we looked at the reports of whether they had mentioned receiving or using bedhead elevation, dietary modifications, or any of the 3 groups there: the proton pump inhibitors, H2 antagonist, or the pharmacy benefit managers approved antacids. WT certified Barrett's disease and WTC certified esophageal cancer were also taken into account. We also conducted sensitivity analyses where we limited the analyses to those who were GERD certified. Characteristics of the 19,000 who were kind of included in the study. Most participants were between the ages of 30 and 59 years old and were male. For the intermittent GERD group versus those who were unresolved, the intermittent GERD group was younger at the visit when they first reported a diagnosis. They more frequently identified as Hispanic, they more frequently identified as Asian, and they more frequently had a BMI that was under 30. The resolved GERD group versus the unresolved more frequently reported their race as Asian or other, more frequently reported their marital status as single at their initial health evaluation, more frequently had a BMI less than 30, and less frequently were certified for WTC-related GERD. Comparison here of like the groups to some extent. So the GERD resolution group was 82% of the group overall. 6.3% of them had a Barrett's certification, and 0.1% had a certification for esophageal cancer. The intermittent GERD group was 12.5% of overall the group. 4.5% of them had a Barrett's certification, and 0.1% had an esophageal cancer certification. For the resolved GERD group, there were 5.5% overall of the 19,000 plus. 0.7% had a Barrett's certification, and 0 had an esophageal cancer certification. Okay, these are comparisons between the intermittent group and the unresolved group, adjusted odd ratios. Those items that are bolded for these univariate statistics are the ones that were significantly different. So the GERD certified versus not, so that the intermittent group was less certified. As we said earlier, they had more follow-up in terms of years. Nancy, jump in if I'm not quite getting this right, please. They reported less bedhead elevation before resolution. They reported more dietary modification before resolution. They reported less use of proton pump inhibitors and less use of H2RA medications as well. And they were less likely to be certified for Barrett's esophagus.
Correct.
And the analyses comparing the resolved group to the unresolved group. Again, the resolved group was much less likely to be GERD certified. They had slightly more follow-up years. They reported less likely they reported endoscopy or laryngoscopy. They used less bedhead elevation before resolution. They use fewer proton pump inhibitors to treat themselves, less H2 receptor antagonists, and lower amounts of pharmacy benefit manager antacids before usage, before resolution, excuse me. And they had less frequently Barrett's esophagus certification. For the interactions, which is kind of like our key finding here, in terms of GERD treatment services, members with more GERD resolution were those who implemented dietary modifications and who used PPIs, or those who implemented dietary modifications and who used program-approved antacids. So it's that combination which we found to be most common in those who had some sort of resolution. The other interactions were not statistically significant. Discussion. Most GERD resolution was reported by people of color. Those who had a body mass index under 25. People with BMIs under 25 experienced less GERD in the general population, and GRC members with lower BMIs experienced more GERD resolution. Those who had longer post-diagnosis follow-up reported more GERD resolution. And those who implemented dietary modifications together with proton pump inhibitors or program-approved antacids, again, reported more GERD resolution. GERD treatment services service utilization was consistent with clinical guidelines. PPIs were the only therapy with less use after the earliest reported GERD resolution, whether it was intermittent or without relapse. Members certified with WTC-related GERD who reported having an endoscopy, who used medications without dietary modifications, or used bedhead elevation, and members certified with Barrett's disease, 5.8% of them, or esophageal cancer, 0.1%, may have had more severe GERD and reported little resolution in our group. Members with less than 1 year follow-up were excluded. This kind of effectively reduced the percentage of people reporting resolved GERD and thus underestimated resolved GERD. So we kind of just set that line, if you will. You needed at least 1 year of follow-up, and so we excluded people who did not have at least that 1 year.
Let me just jump in to say that
Please.
this is a very important point, because people who responded to initial PPI treatment were in that group of less than 1 year.
Got it. Thank you. Potential limitations of the study. There are no available data about the types of dietary modification or lifestyle changes that people made. So they're just very basic questions, no more detailed information. We have large N's, and that increases statistical significance. And the Hosmer-Lemon Show results indicated there was poorer model fit for resolved GERD than for the intermittent GERD group. However, the results of the 4 regression models were very similar, indicating the results were robust. As GERD is commonly diagnosed solely based on self-reported symptoms, we think that reliance on self-reported GERD here does not weaken the validity of GERD status, resolution, and/or certification, because while not all were certified as having WTC-related GERD, the criteria for certification are, more complex and not necessarily indicative of members having of their GERD status. More limitations from visit 1. Follow-up time for those reporting no resolution and resolved GERD was similar, but those reporting intermittent GERD had greater than or equal to 3 years greater follow-up. This suggests that some members reporting resolved GERD may join the intermittent GERD group over time. However, GERD duration from earliest GERD date for members with resolved GERD was less than half, 5.6 years, that of members with intermittent GERD, indicating that follow-up or recall bias would minimally affect their resolution permanence. Conclusions: use of GERD services was consistent with clinical guidelines. Members experiencing resolution may or may not have had less severe GERD, as early diagnosis and intervention might increase the likelihood of earlier and more permanent resolution. Only a modest proportion achieved resolution, 5.5%, most of which was attained via use of PPIs and dietary modifications. However, resolution may have been underestimated by the exclusion of members with less than 1 year of follow-up. We'd like to thank the WTC Health Program and Data Center staff, the labor, community, and volunteer organization stakeholders, and the WTC General Responder Cohort, who so readily and generously gave of themselves in response to the WTC terrorist attacks, and to whom the WTC programs are dedicated. This study was supported by grant sponsor Centers for Disease Control and Prevention and National Institutes for Occupational Safety and Health through cooperative agreements. I'm not going to read the numbers that are listed there. I'll keep them up for a moment. And that's the end.